ISTM is pleased to present the online educational webinar called Rabies, Global Hotspots and Risk to Travelers. This webinar was produced by the Professional Education Committee of ISTM, and the planning committee includes myself, D. Scott Smith, chair of the PEC of ISTM, as well as Dr. Aisha Khatib, co-chair of the PEC of ISTM, and Dr. Yen Bui, who's a counselor for ISTM on the executive board. So a special thanks to our sponsor, Sanofi, who helped provide with an unrestricted educational grant to support this program. It's our pleasure to introduce today's moderator, Dr. Yen Bui.
Thank you, Scott. It's my pleasure and an honor to be with all of you today to discuss this important topic with our impressive panel of experts. I am delighted to introduce our first speaker, although he needs no introduction. We all know and love Dr. David R. Schlim, distinguished past president of the International Society of Travel Medicine and longtime editor of the CDC's Yellow Book. With decades of experience in travel medicine and numerous publications, David is a wonderful writer and he has won awards for his books. And he also brings a wealth of knowledge to today's session. Our second speaker is Dr. Oula Itani, an infectious diseases physician at the Institut Pasteur Medical Center in Paris. She specializes in travel medicine and tropical diseases, providing both pre-travel counseling and post-travel care. Dr. Itani is also an active member of France's largest rabies center, where over 1,400 patients are treated each year for post-exposure prophylaxis. So Oula also has a wealth of knowledge on rabies. Welcome to you both. Welcome to all of our participants from all over the world. And let's begin with our discussion. Over to you, David.
Well, welcome everybody. Sorry for the bit slow start. I'm really happy to be here and talking about rabies, which is something I've been really interested in for a long time. Now, the title of my talk is Are Rabies Exposures Avoidable? This is something that in travel medicine, I don't think we've have focused on enough. And only in recent years did I become really interested in this idea. So I'm going to talk about that and education of travelers before they go. And then Oula will talk about all of the issues involved in treating people after they've had an exposure, because she has this vast experience in Paris. So I start off with an example of a 23-year-old man, and he had a 21-year-old girlfriend, and they were on the beach in Morocco, and they found a puppy, and they were playing with the puppy. I don't know how long they had been with it, but at some point the puppy got a little bit aggressive and bit the girl on the finger, and the boy tried to stop the puppy, and it bit him as well. And then 3 days later, the puppy died. And they buried the puppy, so they knew it had died. And I guess they, felt a little sad or something like that. But they didn't seek any medical treatment. They didn't seem to have any suspicion of rabies. And so, excuse me. So a month later, a man became ill, and a diagnosis of rabies encephalitis was made. And after prolonged intensive care, he died from his disease. So what about his girlfriend now? She's had the same exposure. She's still okay. So they started post-exposure prophylaxis right away with RIG and rabies vaccine, and she apparently has remained well. Why did he die? And why didn't she die? He died because he didn't know about rabies. I think that's what we can say. I didn't get a chance to talk to him, of course. But she didn't die because she got post-exposure prophylaxis, even though it was a month later, before she developed encephalitis. And this demonstrates the variability of rabies, and I'll highlight why that's the case a little bit later in my talk. So how many travelers die of rabies each year? How big a problem is this for travelers? Is it 2,000 travelers. There's 50 to 70,000 deaths from rabies in humans each year, estimated, mainly in India and Africa. But how many travelers die of rabies? Maybe it's only 200. 20? Could it be as low as 2? Or are there none? Well, we know there's just was one. So really, on average of only 2 to 3 travelers a year die of rabies. Now, each one is its own tragedy because from what we know about the prevention of rabies, they're all preventable, and that would be our goal in travel medicine. So how can we accomplish that? So who dies of rabies? Which of these travelers? Are they travelers who get an extensive bite, savaged by a dog on their face? Is it someone who gets a bite but just couldn't get to post-exposure prophylaxis in time? Was it somebody who got post-exposure prophylaxis but it didn't work? Did they get a bite and then decide not to seek post-exposure prophylaxis for whatever reason? So the answer is the slide's not moving. There we go. They received a bite, but decided not to seek post-exposure prophylaxis. So I think this is one of the key take-home messages from this talk, is that the people who die are people who knew they were bitten, but decided for whatever reason not to get post-exposure prophylaxis. Now, what could some of these reasons be? There hasn't been a study of this, but from my own experience and reading, it seems like some of them knew, some of them just didn't know about rabies. We have to guess that maybe the Austrian guy never heard of rabies but maybe he'd heard of rabies, but decided that maybe a puppy can't have rabies. This is a common misconception and needs to be highlighted in the pre-travel visit. Puppies can have rabies and do transmit rabies to humans. Maybe it didn't look ill. Maybe they thought they provoked the attack by approaching the dog. Maybe they thought there's no rabies where they were particularly, or maybe they thought it was just a minor wound and didn't need any treatment. And then we wonder sometimes whether they're just worried about the expense. Maybe they've heard it's really expensive, and so that helps them decide that they don't need rabies prophylaxis. So it led me to think that maybe a travel medicine visit isn't sufficient. Only half of travelers who travel seek pre-travel advice. We know that. And so maybe something to consider, a 1-hour specialized class somewhere in high school about rabies, the risk of rabies associated with travel and so on might hit more people to avoid this problem of having an exposure and having rabies that could be prevented and they make the wrong decision. So how many people are exposed? Well, there's these various airport and returning traveler surveys, which I think I don't know how to really interpret, but you can see they've been done in Bangkok, Frankfurt, Israel. But the bottom line is that between 3 and 31 per 1,000 travelers felt that they had some kind of bite or scratch or lick exposure while they were traveling, but only about a third of them felt that it was significant enough, or whatever reason, to seek post-exposure prophylaxis. That's what the PEP is. So what does that mean? So we got to figure that if they didn't seek post-exposure prophylaxis, what's the number of travelers in these studies who developed rabies in light of what that survey showed? And the answer is 0. So you get 30 per 1,000 and 34% seek post-exposure prophylaxis, yet nobody got rabies. And so let's look at what that would mean if we use some people have looked at those surveys and said we have to give pre-exposure prophylaxis to every traveler because look how many are exposed. But what does it mean? So I did a little bit of research and found that there's about 172 million non-Asian travelers that visit Southeast Asia and South Asia each year. I used a figure before COVID because then it got a little messed up there for a while. And if we go back to even just 1 in 1,000 are bitten, then if we extrapolate that, that would be 172,000 people are exposed to rabies. And if only 34% of them seek post-exposure prophylaxis, that leaves 113,000 untreated bite exposures. And yet there's only 1 or 2 rabies deaths per year. So using those airport surveys doesn't seem to really reflect the actual risk. And so possible reasons for this discrepancy between the exposures and actual cases of rabies in those who did not get post-exposure prophylaxis, perhaps the animal didn't have rabies. So the percentage of dogs, street dogs in various countries around the world who have rabies at any given time is not really known because they can't, the only way to know if they have rabies is to sacrifice the animal. So you can't go kill every animal and then decide how many of them had rabies. It's probably a really small percentage at any given time. And monkeys, who account for a significant amount of the exposures in travelers, actually rarely have rabies. And so it's also something we don't realize, that every bite from a known rabid animal does not result in encephalitis for reasons that I'll show. So even up to 20 to 40% of bites in some studies from a known rabid animal, the person did not develop encephalitis despite not getting post-exposure prophylaxis. And maybe some people who report an exposure on an airport survey had, a lick to intact skin or a very minor scratch, or had something that might not have led to rabies in any case. So the best place to prevent rabies in travelers, and this is the main point of my talk, is at the pre-travel visit. It's an educational issue. It's just not a matter of whether they get pre-exposure immunization or just are going to rely on post-exposure prophylaxis only, but they need to know about rabies in order to be able to prevent it. So there's 2 ways that you can help people not die from rabies. One, help them avoid getting bitten by a rabid animal in the first place. And this is the thing that I don't think we have stressed, because I think that we've had this feeling that it's kind of random bad luck, and not that it may be something that the traveler has some control over, which would really make it easier for the traveler. And then in the case in which they are bitten, they need to know what to do, and they need to know when to do it. So now, what is rabies? So rabies is a virus, and it causes encephalitis. And it's nearly 100% fatal when it reaches the brain. And so that's why there's so much concern about rabies. That's why we're having a worldwide seminar right now to talk about it, because a lot of anxiety among travelers once they're bitten, a lot of anxiety among those who care for them to make sure that they can prevent rabies encephalitis. So the virus is passed in the saliva of mammals who are infected. The infection goes to their brain, and then it goes out to their salivary gland, which is how the virus is passed on. And there's a period of time when in a dog in particular, that the virus can be in their saliva before they show any symptoms from their brain. So a week or more. And so whether the animal looked ill or not is not the issue in terms of whether it could transmit rabies. So when it bites the person, the virus is deposited in the skin, or if it's deeper, into the muscle of the person who receives the bite. Here's the key thing. The virus does not go into the blood, not like HIV, not like hepatitis B. It just stays right there in the tissue. And that's the key difference. That's how everything that we do about rabies is based on this fact. It stays right there and then has to try to gain access to the synapse of a peripheral nerve, has to get taken up in a synapse. It can't invade the axon. And so once it's in the nerve, then it travels along the axon all the way to the brain. And once it reaches the brain, then infection, as I said, is virtually 100% fatal. And once it's in the nervous system, then antibodies and cells and stuff can't reach it to fight the infection. So we need to prevent the virus from entering that nerve. That is our whole purpose of everything that is involved in preventing rabies once there's been an exposure. But because we know about the exposure, so if you're bitten with Japanese encephalitis, with a mosquito carrying Japanese encephalitis virus, you're never going to know whether it had the virus or not. It might be possible to prevent Japanese encephalitis with a shot if you knew you were bitten, but you don't. So in this case, you know you're bitten. That gives us this opportunity to use post-exposure immunoprophylaxis to prevent the virus from entering the nerve. But because the virus is just sitting there in the tissue and maybe multiplying a little bit in the muscle and then trying to spread close to a nerve and get up there, the incubation period is not predictable at all. All we know is the averages, but it doesn't go through a specific cycle like some other pathogens that we know about that have a predictable incubation period. So it's highly variable. As far as I've been able to see, there's one report of someone who developed rabies encephalitis within 6 days of a bite. It must have been inserted directly into a nerve, gone straight to the brain, but that's really, really rare. The average time from bite to symptoms is 45 days. That's what gives this leeway sometimes when people have to travel to get shots, or like the woman in the example at the beginning who was a month later, still had not developed rabies, still got shots and still prevented rabies. But we do know that 98% of the people who are destined to develop rabies encephalitis do so within a year. However, there are well-documented cases of people developing rabies after a bite several years, 6, 7 years or more after the initial bite, and then rabies evolved. And they were able to prove this really clearly in somebody who moved from India to the United States, never went back. When they died of rabies, the virus had the genetic profile of a virus that was in dogs in India. So that is the answer to the question that patients have asked me many times in the past. If they have a very minor exposure and are reluctant to take prophylaxis, then they say, well, if I don't take it, when will I know that I'll be safe? And the answer is, it'll be a long time, be very nerve-wracking every time you get some pain or a headache or something. So that's an issue, and that's the answer. Months or years. So knowing where the virus is and when the exposure occurred makes it possible for us to do things to prevent it from entering the nerve. And this is done with two approaches: with human rabies immune globulin antibodies against rabies injected at the site of the wound to try to get it right against the virus and bind the virus, which prevents its uptake in a nerve, and then followed by a series of injections of rabies antigen to stimulate the person's own immune response. And those two things are virtually 100% effective at preventing rabies if they're applied appropriately. And so the post-exposure protocol varies around the world. In the US, it's on day 0, which is the day that you start, not the day of the bite, but the day that you start vaccine. And then 3 days later, 7 days later, and 14 days later. When I started out, there was an injection at day 28 and also even at day 90. Some of you might be old enough to remember that. They decided to drop the 90 a long time ago, and they even dropped the 28 when they found that there really wasn't much of a boost between the day 14 and the day 28 dose. But we do give that additional dose if there's any reason to believe that the patient may be immunocompromised and needs some extra antigen. So the WHO, World Health Organization, accepted post-exposure prophylactic regimens are here. So the first one is the US one, and then there's sometimes intradermal, tenth of a milliliter, sometimes 2/10 of a milliliter are given on different sites on days 0, 3, and 7. These regimens exist because in the resource poor world where people are seeking post-exposure care, they sometimes have to go back to their village and can't stay around for a month or more, so they try to have more rapid protocols. And so you can see here that different protocols exist, and they all work. Sometimes we're really worried when someone starts a different protocol overseas and have to decide, excuse me, whether to finish that protocol or restart them on our own protocol. And I think Ula will address this issue. I'm sure she's had a lot of chance to see that. And then one of the big fears in travel medicine that I've always encountered is that we think that a traveler will die trying to get to post-exposure prophylaxis. Maybe they're on an island in Thailand somewhere, or Vietnam, and maybe it's hard to get a ride and it takes a while, or it's a long journey to where they need to go. But to my knowledge, no traveler has ever died trying to obtain post-exposure prophylaxis that was correctly given. They died because they didn't go at all, as I mentioned earlier, or what they got in the end wasn't appropriate. They didn't get their wounds injected with immunoglobulin, or something else wasn't quite right. That's pretty rare, but those are the circumstances. And so I think that's important for us to know, that to tell travelers that as long as they're attempting to get to post-exposure prophylaxis, even within 3, 4, 5 days or longer, that they're likely to still be able to prevent rabies encephalitis. Now, because human rabies immunoglobulin and some other products, equine rabies immunoglobulin, so it can be expensive and rarely available where it is needed, because human rabies immunoglobulin is made by purifying rabies antibodies from the plasmapheresis of immunized volunteers. So volunteers get immunized against rabies, and then a while later they draw blood, and the part of the immunoglobulins in the blood are rabies antibodies. And so that's where RIG comes from. But you can imagine it's expensive and there's not huge quantities of it. And so to get around the problem of having to give RIG, second strategy approach, which is to give some amount of immunizations prior to travel. In 2018, WHO decided that 2 shots before travel was adequate pre-exposure. US looked at it and decided that that's true, but that maybe a 3rd shot or rabies titer might be needed within 3 years, as I'll mention in a moment. But by getting these things, it sets up a cell line of cells that'll recognize rabies virus and pump out antibody when it's exposed, and also gives some level of already circulating antibody that falls over time. So as I said, WHO approved pre-exposure regimens of 2 doses. Now, this was great because initially, for everybody, it was 3 doses within 21 to 28 days, 0, 7, and then 21 to 28. And that was hard for a lot of people who come late to their pre-travel visit to do. So now at 2 doses, it's much easier to have people elect to have pre-exposure immunization. And so the intradermal pre-exposure is approved by WHO if you do it in 2 sites, and it's given 7 days apart. And so, as I said, US accepted that. I was on that working group for the CDC and had recommendations to the ACIP committee, which published these recommendations. And but then it wasn't, this 3-year period was based on a lack of further blood drawing in people at 3 years who'd only had 2 doses, and not because there was any evidence that it didn't work. So WHO decided that it does work. We were more conservative. I think it causes kind of difficulty to have this in-between thing. They talked about drawing a titer before 3 years. And if it was adequate, then you wouldn't need to give any more doses. But in the US, titers are difficult to obtain, sometimes takes a month to get, has to be sent to a special lab. And so just giving a third dose is easier. It's a little more expensive, but it may be easier. And it should be given within 3 years. So you can give 2 doses, send them traveling, and then try to get them back for that third dose sometimes. If they don't get that third dose before 3 years, then it's a little unclear what to do, whether they need to start over if they have a bite exposure after 3 years. So like I say, it's not a very happy situation in terms of clarity, but I'm hoping it'll clarify at some point. But the ACIP committee, which is the one that would make these recommendations, has been virtually disbanded in the United States, as you know. And whether they'll take up travel vaccines anytime soon, we don't know. So it may be that we'll have to rely on other sources for that. So the bottom line is that you should remember and not be so anxious about rabies vaccine may be one of the best vaccines ever made. It is so highly immunogenic. There's some studies where people got a tenth of a milliliter intradermal, 2 doses, and a year later, it was completely boostable just from those 2 primers. And so we shouldn't be so anxious about different regimens in terms of pre-exposure because they almost all work. And so I think the best thing to do, if your country has some recommendations, stick with those. Don't go out on a limb doing, because if the worst case scenario happened somehow, you wouldn't have much protection. But you can read the literature, make your own decisions if you want to about intradermal versus intramuscular, and recognize that most all pre-exposure regimens will induce adequate antibodies. Now, why would you want to give pre-immunization? Because the need for RIG is eliminated. That's probably the biggest reason. It's virtually unavailable in almost all the destinations where it's needed. In all of Asia, the reliable places to get RIG is in Kathmandu at the clinic that I used to run. It's now run by Prativa Pandey. We always have it. Bangkok and many cities in Thailand. Thailand's a very rabies savvy country. And Singapore. In Africa, often it's only in Johannesburg and in South Africa. And so you have to travel to get RIG. So if you get pre-immunization, that problem goes away. And then the post-exposure duration of treatment goes down from 4 doses to 2 doses and 14 days to 3 days. So in terms of interruption of the trip, most people can figure out how to stick around and get a second shot 3 days later, but figuring out where you're going to get day 3, day 7, and day 14 on time while still trying to pursue your holiday or travels around if there's multiple destinations. I've had many, many conversations with travelers in Kathmandu about trying to figure out whether they can get it in Hong Kong, whether they can get it in Laos, or wherever they're hoping to go. So that when you have a 3 days, two doses 3 days apart as a booster makes it much easier. And then we think there's an increased chance of protection if you're delayed in getting to post-exposure treatment. Once you get there and get those boosters, you get a much more rapid response because your body's already primed to create that response. And so that can help. And also, it's possible that if you had an unnoticed or unreported exposure, that this pre-exposure immunization could offer some degree of protection against that. We've been reluctant to promote that because we don't want people to say, well, I'm pre-exposed and I don't need a booster. We definitely want to say that they need a booster. But the fact is that that no one who has been pre-immunized and subsequently boosted after an exposure has ever developed rabies. So I jumped ahead, but this eliminates the chance of of the post-exposure treatment failures due to not injecting all the wound with rig, not giving it appropriately, and so on. So there have been some post-exposure treatment failures in travelers and in local people, even when it's supposedly given correctly. Given correctly, I don't think there's been failures in travelers. There might have happened, but in local people, they're described in studies. But the fact is that if you give pre-exposure immunization and they get boosted, then it has never failed. There are no examples in the literature. So that, for someone who's worried about rabies, might be one of the best reasons, excuse me, to get pre-exposure. But now there's a strange thing that is beginning to be talked about, and it's the fact that we don't have any case reports of somebody who got pre-exposure immunization and later got bitten, didn't get a booster, and then showed up with rabies. If such cases exist, they have not been reported yet. So I don't know what that means, other than it gives a higher degree of safety. We don't want to promote that as that you're immune to rabies. That would be wrong, but it means that there's a higher degree of safety from being pre-immunized. Now, in the United States, where we know drugs and vaccines are higher than anywhere in the world, rabies vaccine currently costs about $500 per dose to administer. My cost in my clinic is about $440 to buy the vaccine before it's administered. I found out from ULA that there is about $88 per dose in US dollars. In France, quite different, but considered expensive in France because other vaccines are cheaper. And so in different countries, I think in Canada, it's about $200 per dose. So that really helps. People say, well, if you have enough money to travel, you should have enough money to get vaccines, but it's not really true. If you have to get 2 doses each, and it's $500 each, that's $1,000 per person. And if there's a family of 4 going to Bali or something for 10 days, it adds $4,000. That's the whole cost of the trip practically. Every once in a while, I joke with travelers and I say, well, you can afford to go on the trip or you can afford to prepare for the trip, but you can't do both. It's not always being worthwhile. If we had an inexpensive rabies vaccine, like the equivalent of a typhoid vaccine or hepatitis A vaccine, even if it was 2 doses, I think there'd be much more universal uptake of that. And it's something we could strive for, but so far we don't have that in the US. It's like taking out an insurance policy because you do have this second chance to prevent rabies. Think about it. If you couldn't prevent rabies encephalitis after a bite, it would be a universal vaccine of childhood wherever it was affordable, because that would be your only chance to prevent it. But because we have this second chance, it can be this big expense later on. And the other reason for getting pre-exposure immunization is to preserve the scarce supplies of HRIG into destination countries that are being portioned out among severe exposures in local people. And so, on the other hand, HRIG was only available in Nepal because it was at our clinic to take care of foreigners, and we made it available to local people. So it can swing both ways depending on how it's going. But most of the time, they don't like to use up their rig on travelers. So if you're pre-immunized, you don't do that. And so it's like taking out an insurance policy. You pay up front, and then it avoids a large expense later on, and also a lot of anxiety. And I found out, to my shock, that emergency rooms in the US can charge $20,000 or more to administer rig and the first dose of vaccine. It's the actual cost of the rig in that situation, depending on the weight, would be $4,000 or $5,000. So I don't know how they get away with those kinds of charges, and I don't imagine that's done in other countries. But for people without adequate insurance, um, just go into debt like that just from a bat flying into them when they're walking around at night. I live in a national park, a lot of bats around. Um, so the main thing is whether you're immunized or not, no one wants to get bitten by an animal and have to seek post-exposure care. So the question that I started off this whole talk about, is it possible to avoid animal bites while traveling? Is that possible? Can we have that as a strategy? So again, education, again, life or death importance if they know about rabies, because knowing that they need to go get shots is the life-saving thing, and not just a discussion in terms of just vaccines or not. Okay, what's the strategy? So this is what you must cover with every patient that comes in. You can do it quickly, but this is something that someone at a pre-travel visit, if you have time, if your system is set up for it, that should be covered quickly. Is there rabies where they're going or not? Yes, almost always yes. And then discuss the two vaccine strategies, pre-exposure versus just relying on post-exposure. Bite avoidance is something that I think people have been reluctant to talk about because they don't know what to say. So we'll get into that more. And then they need to know what to do if they are bitten, even if that involves flying to another country. And then, where they would try to fly to and where they could try to obtain PEP on their given trip, if you know what that is. Okay, existence of rabies. The main thing is to distinguish between what we call terrestrial rabies and rabies in land animals and bat rabies. So bat rabies can exist even in destinations that have no terrestrial rabies, for example, Australia. And so the only rabies-free destinations have no terrestrial rabies and no bat rabies. So that's something that people need to know. Any exposure to a bat that slams into them or in contact with their skin or their hair requires post-exposure prophylaxis anywhere in the world. Now, these are the types of exposures that have led travelers to seek treatment. 61% were dogs, 25% monkeys, some cats, and some bats while traveling. Now, bats account for a lot more rabies exposures in North America. Obviously, we don't have stray dogs or monkeys. More feral cats than we used to have. That's becoming an increasing issue at home. But the fatal cases of rabies are mainly due to dogs. 5% of them were due to bats, and some it couldn't be determined. They died of rabies, but it wasn't sure what the exposure was. But it's important to notice that none were due to monkeys. So even though a lot of the exposures are due to monkeys, as I mentioned, monkeys rarely have rabies. Now, rabies virus has adapted to its host in all places around the world. So there are viruses specific to certain bat species, viruses specific to the dogs of the subcontinent. But monkeys don't have any rabies virus of their own, except in South America, where there's some marmosets that have rabies. They're the only ones. But so the only monkeys that are able to transmit rabies have likely been bitten by a dog. Now, are rabies exposures random, or are they an avoidable risk? And what evidence do we have? Well, what I began to notice is that it's very rare to find a traveler, to encounter a traveler who is bitten more than once in their life while traveling. So they're bitten once, and then it almost never, ever happens again. When I've asked this at ISTM conferences, there's one person will know one traveler who had that. So it's very rare. And then it's rare for experienced travelers. When I ask at ISTM how many of the people attending the conference have ever been bitten, also like one hand goes up out of like 300 or 400 people. And so, and expats who are used to living overseas rarely get bitten unless it's, trying to save a stray dog or something that puts them in a special situation. And so I think there might be something to this proverb that says, once bitten, twice shy, suggesting that one exposure makes them more aware of, of an exposure a second time. But then what do they do? Okay, so how to avoid dog bites. So they account for 90% of exposures and 99% of human rabies deaths. Why? Because we tolerate dogs living in our cities, in our towns, and we live with them. And so when they're not vaccinated and they're a sufficient population, they pass rabies among themselves. There are efforts to control that, big efforts. I'm not able to talk about those these days, but some, capturing dogs, neutering them, vaccinating them, and then putting them back on the street where they occupy an ecological niche so that the dogs don't reproduce faster after the dogs are removed. Um, so, what is it that we do, those of us who have never been bitten, and most of you who are listening, I'm sure? So, being aware of the risk, being vigilant when you're out on the streets in a kind of secondary way, not like, don't talk to me, I'm looking for dogs, but just peripheral vision. Every year I go back to Nepal and I kind of look, what's going on? Where are the dogs? And just making sure that I'm not walking into danger in some way. Avoid petting or feeding them, even though you might feel some sympathy and compassion. Of course, the dogs would rather be owned and taken care of their whole lives, but they don't have that option. But we can't help that. And it puts us at risk if we start putting our hands in their mouth and being close to them. When dogs are fighting with each other, they can sometimes turn around and bite you. So you want to keep a big distance from that. And then we found some exposures when people stepped through a gate blindly and there was a dog laying in the sun and you stepped right next to its face and it bit you and so on. So be careful where you step where you can't see. Anyway, I hope this video plays. It's kind of jerky on Zoom, but what I'm showing is how distracting it is when you're new in a place. People trying to sell you things, your view is obscured. There could be dogs around, and you're not thinking about it, and you're kind of irritated that people are trying to sell you things. And I think those are some of the things for new travelers that can be a problem. And then in this video, I was walking around Kathmandu and just showing how there should be sound and the dogs are barking. And so just being aware as you walk through of what the dogs are doing. There's a dog not paying attention to me. And then here's a dog walking towards me, but obviously not very interested in me. So that kind of vigilance can be enough to prevent, having to suddenly deal with the whole anxiety of being exposed to rabies. So if it's random, then the risk should not be avoidable. And the more you travel, the more bites you might expected to have. But it's the opposite. So I think that we need to really take this to heart and figure out how to make this happen. Bite avoidance is the best preventive measure. No bite equals no chance of rabies. When I say bite, I mean bite, scratch, lick, the ways that you're exposure, but it's easier from a lecture point of view to just use the word bite. No chance of rabies equals no need for post-exposure prophylaxis, no interruption of the trip, no additional expense, and no anxiety. For those of you who've treated people who've been bitten, you're aware of how much anxiety there is. Even after they've gotten their post-exposure prophylaxis, they're still not 100%. Convinced sometimes. And so you avoid that whole thing if you're able to not get bitten. So is there a way to teach this wariness to travelers? And so this, I think we need some research. We need to ask ourselves, what do we do? That's what I've been trying to do. And you guys also need to chip in and say, what do you do to avoid getting bitten when you're traveling? And then we need to synthesize this into some good instructions that we can use for people. And then we learn what not to do. We need to get these histories from bitten travelers. Maybe Ula can give us some idea about the ones that she ends up treating post-exposure. get a detailed history. What were they doing? What were they thinking? Were they just on their way to breakfast? Were they thinking what they're going to do that day? And then you say a dog ran out of an alley and bit them. Could they have been aware of that dog? Did they even see it before they were bitten? Were they interacting with the animal? What kind of environment? Were they in a busy downtown bazaar? Were they on the outskirts on a lonely road? These things we need to find out. And the and then in terms of bite avoidance in monkeys, different situation. They don't tend to attack people at all. Um, and and so they only want food. And so if you're carrying food in your backpack, in your pocket, anywhere on you, monkeys can smell it. They will sometimes jump on you to try to get that food. And even though they're aware that sometimes people go shopping for food and carry it in little plastic bags, you could have shampoo, but they don't know that. They'll spot the bag and maybe attack you, try to grab that bag. And then when you try to fight them off, you get scratched, bitten, and there you are. You're suddenly in a situation. Um, and so, as I talked with Ula the other day about it, most monkey encounters are not random. They occur in a known preserve or locale. In Kathmandu, there's two main places, what's called the Monkey Temple in Swayambanath or Pashupatinath, a temple area where there's monkeys. In Bali, it's the sacred monkey forest. In Thailand, there's two places, the Monkey Beach and Lopburi Monkey Temple. And so when people go to these places where there's a lot of monkeys and interact, they get bitten. And so we did one study years ago where 50% of all the tourist exposures to rabies took place at Swayambanath, the monkey temple. But it was both dogs and monkeys, not just monkeys. But there can be a lot of monkeys, as this photo shows, and a lot of people standing around. But again, they won't attack you if you're not carrying food or trying to get too close to photograph them or to try to feed them or to do something that makes them interact with you. They are wild animals. And sometimes it can feel like you're running kind of a gauntlet to get past the monkeys. But again, they won't bite you unless you have food or interact with them in some way. Been a lot of rabies exposures in the sacred monkey forest in Bali. So far, none of the monkeys in the forest have ever been known to have rabies. They don't interact with dogs very much. So, but there is rabies on Bali. And so monkey exposures there need to be treated with post-exposure prophylaxis. But it's difficult to get people not to go. When my daughter on the left and her friend were traveling in Asia and went to Bali, I said, if you could, maybe you don't need to go to that monkey forest. And if you do, really try not to interact with the monkeys. So the next thing you know, anyway, didn't get bitten. But still, what I was worried about was this photo that I was aware of from the internet of this guy who's having teeth of the monkey sunk into his brain at the moment, not brain, but his skull, at the moment that this picture was taken. And he doesn't know it yet. And then he ended up having to get prophylaxis. So that's how people get bitten by monkeys. And these are the other destinations where people love to interact with monkeys, but they get a bite or a scratch, and then suddenly they're in this rabies post-exposure situation. As I mentioned, monkey to human transmission of rabies is very rare to document. It's documented in local people, but in travelers, there's maybe one case that's not really well documented, but there was a bite from a monkey and then later died of rabies after he was back home in Australia. How do monkeys get rabies? Probably from the interactions with dogs. They share the same environment, and we don't know exactly how that happens. Cats can be feral cats, but most often it's the pet cat in the lodge. If you could tell people don't pet the pet cat in the lodge, they will save some grief. I've gotten phone calls from all over. So the cat in the lodge just bit me. Do I need to get rabies shots? Difficult question to answer sometimes. Bats, as I mentioned, anywhere in the world can carry rabies virus or closely related lyssavirus, which causes rabies encephalitis. And I'm aware of an example of a guy who was bitten by a bat in 2005 in Scotland. There hadn't been a case of rabies in Scotland in 100 years, and he got rabies and died. What constitutes a bat exposure? Here's a picture of a bat showing the size of their teeth in a small bat, very tiny, millimeter. So people have died because they've searched for the bite, did not see the teeth marks, decided they weren't bitten. So any contact where a bat slams into your skin, lands on you, and there's some fuss, has to in your bare skin, you have to consider that you may well have been bitten and proceed from there. Rats is something that comes up. I want to talk about it because we always say rats, or the CDC says rats are almost never found to be infected with rabies and have not been known to transmit rabies to humans. Easy to say, hard to live up to. What does almost never mean when the disease is rabies? When I was working in Nepal, an aid worker was asleep in a local home on a bare floor. An animal ran into the house, bit him, and scurried off. He never saw the animal. He came to see me and asked me what he should do about rabies. I treated him. Later, this report came out of Thailand. A 45-year-old farmer was attacked in his sleep by a large rat. They have large rats in Thailand, larger than most places. And he got multiple bites. They captured the rat, killed it, and it had rabies. And so at this Memorial Institute in Bangkok, they see 7,000 post-exposure rabies patients a year, of which 1% are for rat bites, and they treat them. And the virus in the rat is the kind that's associated with dogs. The rats are so big that they can probably survive a dog bite. That's the idea why rats don't have rabies, is that if they're bitten by a rabid dog, that they probably die. So we need to collect these things. And if you want, I'm interested. Send the reports to me. There it is. Take a screenshot. That's my email. And when you have a patient with an exposure, tell me all the details. Maybe collect that. Maybe we can distill this into something that would be of value based on actual experience. All right, now I'm living in Jackson Hole, Wyoming. I'm not treating people for rabies exposure myself, but Ula maybe can comment on this and whether they've collected those stories. So that's the end of my talk. We'll turn it over to Ula to what to do for all the complications of people who are bitten. But I can't help one ad for my memoir, my experience of moving to Nepal, working there for so many years, meeting Tibetan lamas, getting teachers, and so on. Book's called A Gentle Rain of Compassion, if you're interested. So anyway, I'll turn it back over to Yen. Thank you so much for tuning in today to this webinar.
Thank you, David, for this very thoughtful presentation, and welcome, Ula. Over to you.
Hello.
Yes, so you can share your experience with us now. And we already have a lot of questions in the Q&A. So as you can see, this is a perennially favorite topic for ISTM.
Thank you.
Over to you, Ula.
Thank you, David, for that presentation. And thank you for the organizers for inviting me this year to speak again on rabies. So this year we really wanted to focus on prevention in travelers. And so David, I think, did the most important part, which is preventing through education and preventing exposure. I'll be talking more about prevention through immunization, so through pre-exposure prophylaxis and post-exposure prophylaxis. So I have no conflicts of interest for this presentation. I've divided it into 3 parts. Prevention through pre-exposure prophylaxis, prevention through post-exposure prophylaxis. And then in between the two, I thought I would try and share our experience here in Paris with you and try and show you how seeing travelers and managing them after exposure really helps us better understand who is actually exposed and better prevent exposures during consultations, during our pre-travel consultations. So to start with preventing rabies through pre-exposure prophylaxis. This year I really just wanted to talk about the two-dose regimen. Ever since 2018, the WHO now recommends a two-dose regimen on day 0 and day set. So either two-site ID vaccination or one-site IM vaccination. And they do not recommend any further pre-exposure booster, including for travelers who are traveling to high-risk areas. In France, we follow the French guidelines, which are quite similar. We also recommend a two-dose regimen, day 0 and day 7. We only do IM vaccination because for practical reasons. And we don't do any further boosters, except for immunocompromised travelers, where a third dose is recommended, or else, if possible, a serology with only 2 doses and a serology to make sure that 2 doses were enough in these travelers. And then I added ACIP recommendations because they're a little different. David mentioned it earlier on. They also recommend 2 doses in travelers, a 2-dose regimen, but they recommend a booster no later than 3 years or a one-titer check. And so this was thoroughly presented last year during the webinar. I think it's still available on YouTube. But the scientific rationale here was that the studies, as David mentioned, only go up to 3 years, and we don't have enough data after 3 years. We probably think it works, but there's no scientific data yet available on that. And so what were these studies? This is one of the studies that evaluated the 2-dose regimen. It was a non-inferiority trial, and it showed that in healthy adults, ID administration of a double dose, so over here, 7 days apart, was just as safe and non-inferior to a single dose schedule on 3 to 4 weeks. And so the rates of seroconversion in these 2 cases, in between the 2 groups, were similar. And then they added a single booster dose 1 to 3 years later. So that's where the 1 to 3 years comes from in the recommendations to evaluate the anamnestic rabies antibody response. And they saw that both groups were correctly protected. This is another study that also looked at this, but this time with IM vaccination. They also did it with ID vaccination in this study. They compared 2 doses to 3 doses. Both groups had similar rates of positive serologies after pre-exposure prophylaxis. And then 1 year later, they did a 2-dose regimen, 3 days apart, as if the person was receiving post-exposure prophylaxis. And once again, all participants were correctly protected. So that's what the guidelines show and what the studies show. What I always like to see is what's actually done in real life, what happens in real life. This is a survey that was carried out by some of the members in our team a few years ago in 2022. They did a survey among 72 vaccination centers in France, and they asked them whether they use the 2-dose regimen. So already at that time, probably now more people use it. 3/4 of the centers had already started using a 2-dose regimen, but most of them only used it in case of for schedule reasons or for cost reasons. There was only 1/3 of the centers who actually used this regimen systematically in all patients. And the other thing that was interesting in this survey, they asked the health providers if they had ever seen travelers report issues abroad with a 2-dose regimen, because that's something that we regularly see in post-exposure when we manage travelers in post-exposure. We see some travelers who have already received pre-exposure vaccination, 2 doses, a 2-dose regimen. And once they're exposed abroad and they consult, this regimen isn't recognized abroad, and they get a full post-exposure prophylaxis, sometimes even with immunoglobulins. So 10% of the health providers said they had already heard of travelers who had had issues with this abroad. So now what we do is that we have a special stamp that we try and put on our pre-vaccination, on our vaccination cards in our pre-travel clinic, and we also added a little mention on our yellow cards, just to say that the WHO now recommends the 2-dose regimen. So, and I would be happy to hear, if we have time at the end for questions, what your experience is, whether you use a 2-dose regimen, and for those who maybe work or live in endemic countries, whether you recognize this 2-dose regimen in our travelers when they come and see you. The other real life question that we wonder is what actually happens to these travelers who have received a 2-dose regimen once they're exposed and get post-exposure prophylaxis. So we presented a poster on this at CISTM this year in New Orleans. This is the part that interests us today. We looked at all travelers who had received a 2-dose regimen in pre-exposure, and looked what happened to them once they received post-exposure prophylaxis in our post-exposure clinic. So all those who had received a 2-dose regimen less than 3 years ago had positive serologies once they received post-exposure prophylaxis. But what we also see, and that's what's interesting here, is that all those who had received pre-exposure prophylaxis over 3 years ago also all responded very well to a 2-dose regimen after post-exposure, as a post-exposure prophylaxis. So these are small samples, but I think it's still interesting and encouraging results. It highlights what David was also saying earlier on, which is that this is a very good vaccine. Our modern cellular vaccines are highly immunogenic, and probably they work very well. When we look here at the detail, we see that a quarter of these patients had actually received pre-exposure prophylaxis over 9 years before exposure, and one of them had even received his pre-exposure prophylaxis 19 years ago, and he responded well to a 2-dose booster in post-exposure prophylaxis. So probably these patients are well protected, and these vaccines work very well. And so once we said that, sometimes we actually wonder, is PrEP alone even enough? So as David said earlier, we don't want to promote no post-exposure prophylaxis, but these are just things that we think about. And when we were talking with David earlier last week, when we were preparing this webinar, we discussed the fact, and he reminded it earlier, that no cases have been reported in the literature of rabies occurring in pre-immunized patients who didn't then receive post-exposure prophylaxis. So if you know of any of these cases, we would be really interested to discuss this with you at the end. And I added you just a few sporadic cases that I've seen recently in the post-exposure, during post-exposure management. These are 2 patients who had received pre-exposure prophylaxis, a 2-dose regimen, and only received 1 dose in post-exposure. And both these patients responded well to a 1-dose regimen. They had only received 1 dose and came and saw us much later. That's why we didn't do a second dose and simply did serology. This patient had also received a 2-dose regimen, and then didn't do any post-exposure prophylaxis and came and saw us over a year after the exposure. So we didn't at that stage do any additional dose, but we did do a serology, and the serology was also showed us that this patient was well protected. But then sometimes we also have patients like this one who had also received a 2-dose pre-exposure regimen and got exposed 1 year later. And before coming and seeing us, his general practitioner had performed a serology, and the serology was not in favor of protection at that time. And once we did 2 doses, the 2-dose booster, he again had a positive serology. So we definitely don't have enough data on this. We don't want to promote the fact that PrEP is enough alone, but it's just the things that we sometimes think about because we know that this vaccine works very well. And the other thing I can add on that, in this study that I showed you previously, when we look at the rates of positive serologies at 6 months, we see that only 1 out of 2 patients has a positive serology at that time. So we definitely don't have enough data on this to be able to conclude. So that's what I wanted to say today on pre-exposure prophylaxis. Now I wanted to try and show you how our post-exposure management of travelers helps us better understand which travelers are exposed and how we can better counsel travelers that we see in our pre-exposure, in our pre-travel clinic. So this is some of our experience over 3,000 exposures. What we see is that we see as many men as women. And when we look at who these travelers are, it's mainly young adults with a median age of around 30 years old. But we also see a second population here, which is children. 15% of our patients are children who are under 15 years old. So we really try and insist and reach this population also when we're counseling our travelers in our pre-travel clinic. Children tend to go towards animals, touch them, pet them, and get exposed. The other thing we see is where are our travelers exposed? For us, it's mainly Southeast Asia and North Africa. And when we look more precisely, 5 countries account for more than 50% of exposures, not more, sorry, 50% of exposures in our clinic, which are Thailand and Indonesia for Southeast Asia, Morocco, Algeria, and Thailand, Indonesia, yes, for Southeast Asia, Morocco, Algeria, and Tunisia for North Africa. So these are what I would kind of call our hotspots. When we were discussing again last week with David, he said he doesn't really like this term of hotspots, rabies hotspots, because it makes us believe there's more rabies in some places than other places. Once you're in an endemic country, whether there's a lot of rabies or not, you have to consider that the exposure is at risk. So it's not something that's very pertinent. But what is maybe interesting is to try and find out where your travelers are the most exposed. For us, our hotspots of exposure is mostly North Africa and Thailand and in Indonesia. But this can be very variable according to each center. In France, we have very strong historical links with North Africa, so we have many travelers who travel there, but this can vary from one center to another. So I would highly encourage you to try and find out where your travelers are most exposed and really try and insist in pre-travel consultations on these travelers. I know when I see a traveler going to North Africa, Thailand, or Indonesia, I might spend a bit more time than usual discussing rabies and really trying on promoting prevention through education. The other thing that's interesting here is that when we look at monkey exposures, we see that 80% of monkey exposures occur in Southeast Asia. And most of these monkey exposures occur in 2 hotspots, as David also mentioned, monkey forest and monkey beach. So these are things that we really try also and discuss with our travelers when we see them in our pre-travel clinic. When we look at cat exposures, over 50% of cat exposures occur in North Africa, and this number is significantly more frequent among children. So these again are travelers we try and reach during our pre-travel consultations. The other thing which is important is which areas are our travelers more likely to have difficult access to post-exposure prophylaxis. Either because they have limited access to vaccination. In our post-exposure rabies center, we still see travelers coming back from Algeria and Bolivia who have received nerve tissue vaccines. And there's maybe some other countries. These are the 2 countries we still see in our post-exposure clinic. So the WHO no longer recommends these vaccines because they can induce more frequent severe adverse reactions and they're known to be less immunogenic. So if we see travelers going to South America and tell us they're going to be spending 1 month in Bolivia, I would maybe tend to encourage pre-exposure prophylaxis more easily than a traveler who will be spending 1 month in another country in the area. The other thing would be limited access to rabies immunoglobulins. So David also mentioned this. This is a geosentinel analysis that looked at travelers who had started rabies post-exposure prophylaxis during travel and after travel. And among those who started post-exposure prophylaxis during travel, over 65% of them, nearly 70% of them had an indication for RIG, but only a quarter of these travelers actually received RIG in the country of exposures. And for those who didn't receive it, more than half of them could no longer receive it once they had gone back to their home country because it was beyond 7 days. So limited access to RIG is also something that we will consider while counseling our travelers in our pre-travel clinic and encouraging more or less pre-exposure prophylaxis and vaccination. What they found in this study was that travelers who were exposed in Thailand, Sri Lanka, and Philippines were more likely, significantly more likely to receive RIG. And from our experience, travelers who go to Asia often have access to RIG versus travelers in Africa or even South America, where access to RIG seems more complicated. I could have added it here. I think there's also a Dutch study that looked at factors contributing to delayed rabies PEP, and one of the factors that came out was the region, and they showed that access to RIG was more complicated in South America, for example, than in Southeast Asia. So these are two things that will also that we will also include in our decision to promote more or less pre-exposure prophylaxis during our pre-travel consultations. So although David discussed this really well, I had to do a point on behavioral risks because the most important part, as he said, and what I believe, is that the most important prevention is prevention through education. And so education, when it comes to education, behavioral risk, this is what David called help them avoid it. When we look at our travelers, when I was discussing with David last week, he said to me, well, he reminded us now, he said, you travel a lot, Ula, why do you never get exposed? And so when I thought about it, it's because I think all of us here don't have the behavioral risks to get exposed. So I went back and looked with my colleague who helped me, who I think is watching. We went back and looked at the last 2 months of patients we just saw this year in our center. In the last 2 months, we saw 724 people who had been exposed abroad. And among these people, the first thing is that only less than 10% of them had consulted before traveling. And over 95% of them described provoked exposures. So we could understand why they had been exposed. And we had specific details for half of these patients. And when we look at these details, what do we see? We see that nearly half of these patients were petting or playing with the animals. This is a cat. Last year I was traveling in China. I saw this cat that looked very fluffy, but I didn't pet it. So nearly half of these travelers see an animal that looks cute, that looks fluffy. Sometimes they show us the photo. They say, "Look at the animal. Wouldn't you have petted it?" They're playing with the animals, and that's why they get exposed. And not surprisingly, half of these exposures happen either on the hands because they're playing with them, either on the thighs because the cat or the dog will jump up on them and scratch or bite them on their thighs. Another thing that comes back frequently was we saw a sick animal, we wanted to help him, poor animal, or we were feeding the animal, we were giving water to the animal. These are tourists I saw a few years ago who were giving a water bottle to this dog and who then went to the supermarket, bought sausages, and started feeding the stray dogs. So these are obviously these tourists, I don't know if they did get exposed, but were obviously at risk. And most of these exposures occur on hands. So all of this is very understandable. Another thing that comes back frequently is we were in a restaurant, the cat wanted to eat. Here we see a cat waiting to eat or to get food. And so we threw him something, we put our hand down, we pointed, and the cat thought we were going to give him food and jumped up on us. So during pre-travel consultations, we often think of telling people don't approach animals, don't touch them. But sometimes we also forget to say to them, be careful. If you're sitting in a restaurant, don't have a sudden movement. Don't point to the cat because animals may believe that you're trying to feed them or give them something. This also, David mentioned, this was last week I went to Turkey for a wedding, and there were stray dogs everywhere. This is a dog that was sitting on the side of the pavement. We saw dogs laying in the sun, sunbathing. Many people tend to approach these animals to pass close by. We often hear people who are saying, "I went on a hike. I went on a run. I was jogging on the beach. I was on my bicycle and I passed by an animal. I was on a motorcycle and it made a big noise and the dog got scared, or I passed by the dog and it woke him up and he got scared and he bit me." So again, we think of telling people not to touch animals. We don't always maybe insist enough on animal sleeping. Don't try and surprise it because these are patients who are also at risks, travelers who are also at risks of getting exposed. And most of these exposures, again, unsurprisingly, happen on their feet or on their calves as they're passing by the animal. And then 10% of our patients in the last 2 months were exposed by monkeys. This is a video a patient sent me showing me this monkey who was very cute, who then jumped on him and started biting him to play. All of our patients are will describe either feeding the monkey, either wanting to pet the monkey, either just taking a photo with the monkey or taking a video of the monkey, interacting with the animal. Also, creates a risk of being exposed. And then the last thing that I wanted to add on prevention through when it comes to education. So this is what David called make sure they know about it. It's unawareness. I discussed this last year during the webinar too. When you live in a non-endemic country, our population doesn't always know about rabies. I've heard several times people telling us, I didn't even think rabies existed anymore. I thought rabies doesn't exist anywhere in the world. So these were, again, around 3,000, roughly 3,000 travelers. When we look who had consulted before traveling, a large majority of these patients, of these travelers exposed, had not consulted before traveling. And an even larger majority of them had not received pre-exposure prophylaxis before traveling. And when we look at the time in between exposure and first vaccination, the medium delay is quite short, 3 days. But 25% of them get their first dose 12 days after exposure. And I find these are numbers which are really striking. 5% get their first vaccination nearly 6 weeks, over 6 weeks after exposure. 1% get their vaccination, their first dose, 6 months after exposure. And when we ask these travelers, why did you take 6 months to come and see us? Why did you take 1 month, over 1 month to come and see us? It's this systematically, they will say to us, I didn't know there was a risk. I had never heard of rabies. I was having dinner with a friend and out of nowhere it came up, and that's how I found out about it. And I remembered my exposure 6 months ago. So these are, I think this is one of the main things we need to try and raise awareness. People born and raised in non-endemic countries lack awareness. And so that's why our pre-travel consultations are really important. And the other problem, as David also mentioned, many of these patients actually don't consult before traveling. And we see this a lot in pre-travel medicine. I think we can say the same thing about malaria. Those who don't take prophylaxis and who get malaria aren't those who come and see us before. We have a pre-travel clinic here and a post-travel clinic, and it's never the same patients we see. Those that we see, the ones we see before travel, we never see them again, and the ones we see after travel aren't the ones who had come and seen us before their travel. So I think that's one of the biggest challenges now in travel medicine is how do we reach these travelers, the ones who don't consult, because they're the ones who are the most at risk. And I found that very interesting what David said about maybe education through in high school or through schools, maybe we need to start and thinking about travel medicine outside of our vaccination centers. So now, just to finish off, I wanted to show you a bit of what we see after in these patients who are exposed and who come to our clinic for post-exposure prophylaxis. In travelers, there's two things which are which can make management a little bit more complicated. First of all, the unknowns. These travelers often start their post-exposure prophylaxis abroad, and we don't always know what they've received, what vaccines. And the other thing is disrupted travel, disrupted schedules. They travel a lot and can't always follow what is recommended officially. Unknown vaccination is very common. These are examples again of patients we've seen recently where there's no name of vaccination. So we try and avoid most possible to not start over and revaccinate all our patients. So we always try and find clues of things that can maybe help us know which vaccine was used. And one of the clues that we can look at is batch numbers, where now we all got used to seeing these batch numbers that we learned to kind of know by heart. Over here, you see typical Rabivax S batch numbers. Here we have a typical VeroRab or Rabic Pasteur label. This is typical VeroRab batch numbers. Over here, we have typical SPIDA batch numbers. So these are things which help us better understand or help us give us clues and allow us to say these vaccines were good vaccines. We're not going to start over. Another thing that we use to avoid to start over is when the patient has received only one dose abroad with an unknown vaccine, or else has received several doses abroad with only one unknown vaccine. Often what we will do is just add a fifth additional dose to avoid starting over or even performing serology. We say to ourselves, these patients had received at least 4 correct doses. Even if we don't know what dose they received for one of these vaccines, we can be safe and say to ourselves they're correctly protected. But sometimes we have papers like this where we just see rabies or anti-rabies vaccine or RV rabies vaccines or just the dates with no vaccine noted. Sometimes we also have photos that they bring us, but we can't really see what's going on, or we don't really understand what is happening. And sometimes we also have vaccine boxes that we don't know about, and we're not sure are correct vaccines, Rab or Zunovax or Vaxera. These are vaccines that we saw recently. And so in all of these cases, we're obliged to perform serology. And that is because our guidelines clearly state that serology must be done in immunocompromised subjects or in case of disrupted schedules or unknown vaccines, doubtful conservation, administration, unknown vaccines, incorrect route. So I know last year I talked a lot about serology, and many of you, we discussed this later, said we don't have access to serology at all, or it takes, like David says, sometimes up to 1 month to get serology in our country. In France, we can perform serology in any lab. It's for free on Social Security, and we get the results under 7 days. So it's something we use a lot because we have easy access to it and rapid results. But for those who don't actually have serology, I just wanted to show you a bit of our results, because at the end of the day, when we actually perform serology in these patients for who we have no information about vaccination, what we realize is that these patients are all correctly protected. On the last years, we performed 117 serologies for people because we did not know the origin of the vaccine, and nearly all these serologies came back positive. The only one that came back negative wasn't really an unknown vaccine case. It was a patient who had reported previous PEP 20 years ago in Angola, and who didn't respond to an additional 2-dose booster. So he probably hadn't really received PEP. He had no information about it. But all those who had a classic unknown vaccine paper, at the end of the day, we see they're all well protected, and most of our travelers who start prophylaxis abroad are very well managed. The other thing that can be complicated for us is disrupted regimens. This is something that we see also all the time. Patients are traveling, they can't come on the day that they were supposed to come, or they didn't find the vaccine or that on that day, or they were doing different countries, and in one of the countries there wasn't vaccination possible. So this is an example of a patient who started post-exposure prophylaxis, got doses on day 0, never did his day 3, then did his day 7, and then came and saw us at day 11. So we, again, try not to start over. We're going to always try and, if possible, pursue the regimen. Often what we do is we do a 3rd dose, we tell them to come back 1 week later, we do a 4th dose, but then because this is disrupted and we can't really guarantee in our guidelines that this is correct post-exposure prophylaxis, we will always complete with serology, and this patient had a positive serology. Same thing for this patient who started a regimen with 2 doses on the first day, never came back, comes and sees us at day 23. So again, we did a 3rd dose, told him to come back 1 week later, did a 4th dose, and again, this patient had positive serology. Another similar case, day 0, day 3, patient comes and sees us at day 17. We do a 3rd dose, 1 week later, a 4th dose, and again, this patient was correctly protected. And so when we look at our serology results in these patients, all of our patients practically had positive results. Disrupted regimen never seems to be a reason to not develop correct protection. The only ones who had negative results had another reason to not be protected. 2 of them were immunocompromised, and one of them had a high body mass index, which we consider to be a risk factor for non-response. So that's what I wanted to talk about today. If we can take home a few messages, I think the most important one was David's one, prevention through education. 2-dose regimens are validated for pre-exposure prophylaxis. Spotting your traveler's exposure hotspots or places where it's complicated to be managed can help better counsel your travelers when you see them in your pre-travel clinic. Pre-exposure should really insist on education, behavior risks, awareness, and raising awareness and reaching travelers who do not consult before travel is really something that remains a challenge for us in travel medicine. Post-exposure management in travelers can be complicated. It often involves unknowns and disruptions, but when we finally look at serologies in these populations, we realize that our travelers are most of the time well protected. Thank you.
Thank you, Ula. Thank you, David. This is very great. Really appreciate your time. We are a little short on time, so I'm hoping that we can answer a few questions if people are willing to stay on. So, Yen and Aisha, are you ready to rock and roll?
Shall I maybe on?
Yes. We have a lot of questions in the Q&A box. Thank you so much for all this information and for the lively discussion. We will try and answer a few questions, and the rest will send out the answers in the handout. Okay, so the first question, a 65-year-old man on an eco tour of Madagascar. He was bitten this evening with a puncture on the upper arm by a village dog. Seemingly unprovoked attack. No rabies vaccine. It's going to take him 16 hours to get back to the nearest rabies treatment center in the capital city. Rabies clinic tells him H-rig not available, but equine rig is now in stock. It will take another 24 hours for a commercial flight to Johannesburg or Reunion Island, where H-rig is available. What rig should he get? So this question is regarding E-rig. If it's available should a traveler get that?
I think Ula might
Lara,
be able
David.
to answer
Yeah.
that.
Sure.
Well, we have HRIG over here, but ERIG is also recommended by WHO. I think it just has more a higher risk of allergy reactions, but it's I would probably tell him to get ERIG and not travel around the world. I don't know what you would do, David.
I think
Maybe.
that's fine, but also this time frame, we shouldn't be so like concerned within hours,
Yeah,
3 to 5 days. There isn't a
yeah,
case of anyone who traveled during that time who ever got rabies because of that delay. So
yeah,
they have a choice in that case.
yeah.
But
Okay, the next question, I think you touched upon this. Sorry if I missed it, but if someone gets the two-dose PrEP series before travel on day 0 and 7, what is the post-exposure vaccine schedule if they get bitten?
just
I
two
think
doses, 3 days apart.
yeah,
Sorry.
yeah, okay. We have another question about cumulative risk for travelers. David, you talk about cumulative risk for travelers and investment or the insurance you talk about.
I'm not sure what the question is, Yen.
Cumulative risk for travelers, it's not just like a one-time risk, um, but if you travel repeatedly, would that factor of repeated travel makes it uh, uh,
More
more
likely.
likely that you should get pre-exposure vaccination.
I'm sorry, I think when they're just starting out, don't have experience, then planning a lot of travel, that could factor into the decision to get pre-exposure. But the more people travel, my experience is the less likely they're to get bitten over time. Their experience teaches them how not to get bitten, unless they're really unlucky. So, but if you're looking at a given 2 week trip or 1 week trip or something, then you can say, well, maybe it's not worth it. But if you say, well, I'm hoping to travel every year and things like that, then of course that would factor into the advantage of being pre-immunized over time. Yeah.
Okay. Another question on about runners. They're often targets for dog bites.
Mm.
Would they be good targets for pre-exposure prophylaxis?
Well, it's funny. We always talk about cyclists. There are a lot of people who like to cycle along the coast of
Mhm.
Vietnam. There are tours and other places. And I almost have never seen cyclists who get bitten. They get chased a lot, but it seems like the dogs don't catch them very much. I don't know, Ula, in your clinic, do you see people who are chased but also get caught by those dogs?
Well, the ones we see come for post-exposure
Yes.
prophylaxis. So most of the, I think we have a
Like
bias, but yeah,
those
they
are the
have,
ones who lost, right?
yeah, those are the ones that lost the race.
Yeah. Um,
It happens. I mean, I wouldn't say it's maybe not as frequent as the number of cyclists, but
yes. Yeah. Of
it can happen.
course.
Maybe uphill. It's more complicated.
You can't get away.
Yeah.
Thank you. Okay, and I think I will read out a last question. We are currently facing a shortage of rabies immunoglobulin. To what extent can we rely on rabies vaccine alone for post-exposure prophylaxis? Which criteria should guide the decision? Anatomical location of the exposure, type of animal, nature of the injury, or WHO exposure category of the wound. Specifically, which criterion should be considered the most important to prioritize?
Ula?
Well, these are tricky questions. I mean, all those factors are important. I would say, I mean, you need to. David showed it well. Monkeys, for example, it's quite rare to see monkeys who actually have rabies. Most of all, it's dogs. Obviously, if you're closer to the brain, it's more at risk. If you're a deep bite, category 3 is more at risk. So if you have to make a choice, I would maybe put those ones first. But these are things that we're not very used to. I mean, I think that's what where our limits come. We're used to having access to rigs, so it's complicated to make these decisions for us.
Yeah. I think
Yeah.
that it's good to remember that rig offers an advantage in that first week. It's to prevent early entry into the nerve. Someone's with a deeper bite, multiple wounds, something like obviously would prioritize rig because there's so much more chance for the virus to find a nerve. An abrasion type wound, again, WHO distinguishes between that somewhat, but overall, if you skip rig and you get away with that first week, you're probably going to get away with it. So
Yeah,
that's something to consider. It
yeah.
doesn't overall increase the down the road advantage of all that vaccine that you've now gotten and gotten your own antibodies, but it's to prevent early entry of the virus into the nerve. And so if you think of it that way, that can help you guide your decision making, I think.
That's a decision that fortunately we don't have to make in North America. We're very lucky, like to always have a H rate. But I think it's also worthwhile to remember that a good disinfection for 10, 15 minutes with
Mm.
soap and water, it's a very good way to inactivate rabies virus locally. Also, so like you should
Yes.
never forget that
Mm.
when
Yes.
you counsel the travelers. Well, thank you so much, David, Ula, for your generosity in sharing all this experience with us. You can see by the audience reactions that we all appreciated this very much. I will turn this over to our chair, Dr. Scott Smith, and Dr. Aisha Khatib, our co-chair, to close out the session. Thank you again. Over
Thank you,
to you.
Yen.
Thank you.
Thank you, Yen. Thank you, David and Ula, for sharing. We really appreciate the time together and reviewing all that we had here. And I just wanted to also mention that if you want to go to the website, please check on the ISTM website to review the webinar further and also see the written answers to the many questions that we didn't quite get to in the discussion here today. And Aisha, please mention as well how to get to the webinar. I'm sorry, the podcast to uh, reinforce rabies information.
Yes, thank you so much, Dr. Schlim and Dr. Tani, for a fantastic webinar and really informative, and clearly a lot of questions still around this. So we definitely had to pick and choose some. So we'll get to a lot of it. And I think this is really appropriate timing given, World Rabies Day, and given that there actually have been not plenty, well, we're seeing more cases in return travelers who have had bite exposures, and people are more aware of it as well. So I think that's the other thing, is that people are coming in. So we do like to create awareness, not just for our medical professionals, but also for our travelers. And so ISTM does have the Travel Unraveled podcast. And we actually have done a podcast on rabies, that it is for not only for the travel health practitioner, but also for the traveler to give some more guidance and some education around it. So we would recommend that you take a look and advise it to your travelers, and have a look yourself. It's with Dr. Patrick Sojens, who worked on the 2-dose PrEP exposure changes, and Dr. Lucille Bloomberg, who I usually call the Queen of Rabies in South Africa. So that is on the ISTM learning site, and I'll put it again in the chat for all of you. So thank you so much to our speakers and our wonderful moderator, Dr. Yen Bui, and my co-chair, and of course to the ISTM team, Kim Gray, as well, for facilitating all of this today.
Thank you very much. And also
Thank you
just
all.
make sure that you fill out the survey link that's on the content tab at istm.org. And again, thanks to our sponsors, Sanofi, and to our speakers. Appreciate it. Have a wonderful day.